Now, the epidemiology of Ebola is really striking. As you know, for many years and decades, this was viewed as a rare case that people would get because it was so virulent. The patients would die quickly and it would not spread. But this last outbreak proved us wrong. There were over 11,000 deaths which were recorded, but the healthcare system at that point was really under so much stress that it felt that this is only a small fraction of the total deaths and which have occurred. And so this was one of the most major outbreaks that we've seen, and luckily it was reversed and it did not spread throughout the remainder of the world. One of the problems with Ebola is of course in its containment. In that area, there is actually a reservoir, an animal reservoir, which can spread the virus. Luckily, in the United States, we don't have that. If we did have it, the virus get into an animal reservoir, I think we would have severe problems because you never really could stomp it out. It is spread by exposure to bodily fluids and mostly towards the end stage of the disease. If you could remember the experience down in Texas, the gentleman who initially had Ebola was sent home for several days after he was symptomatic, lived in a small apartment with a number of people, mingled in the community, yet the virus did not spread. However, towards the end of life, when the body becomes just literally riddled with the virus and all sorts of different secretions, it is highly infectious and really spreads like wildfire. And of course, in Texas, or not in Texas, but in Africa, the problem is a lot of their burial customs involved touching and transporting the bodies by hand, which resulted in widespread devastation and spreading of the disease. One of the scariest things I think about Ebola is its symptomatology, especially at the onset, in that there is a wide range of symptoms. I mean, almost everybody could have this disease if they came into your ER. I mean, everything from hiccups, sore throat, fever, chest pain, vomiting, aches, joint aches, muscle weakness, skin rash, diarrhea. How in the world can you then, if this got endemic in our animal population, could you possibly screen on the front end patients coming in to say for sure they didn't have this disease? This would be extremely difficult, and that's why taking a history of travel and exposure to endemic areas of Ebola is so important. Now, the APIC just released a survey on Ebola and the preparedness for Ebola a year after the epidemic. And what they found is kind of startling. First of all, the number of infection control nurses and practitioners is really drastically low. 53% of the respondents said that there is only one or sometimes less than one person responsible for this at the facility. And you may say, well, one is fine, but remember, you've got 3 shifts a day, 7 days a week, plus vacations, etc. So if you only have one person, if you actually look at the physical hours, you probably only have a third of that covered, maybe even less. And 41% stated that they had to cover more than one facility. They found facilities that were not prepared or not well prepared for highly lethal contagions such as Ebola. And remember, although we talk about Ebola, there's MERS, there's a lot of other very deadly diseases out there, including totally resistant tuberculosis that haven't hit the United States yet, that we really need to be prepared for. Ebola was kind of the test case, and in my opinion, I think we failed, and I think a lot of people would agree with that we had severe problems in how we addressed this. Now, if this was, polling restaurants and asking, well, how many of you really do you think has a good tasting pizza, and 92% did, that would be a great result. But when you're dealing with a highly infectious contagion where even one failure could result in rampant spread through the community, an 8% failure is not acceptable. 75% reported that facilities personnel, so 25% of the facilities, it's unknown or they may not have enough personnel to address an epidemic. And this is, of course, again, not acceptable, stating that you have 25%. Either you don't know that you can address it or you can't address it. And of course, if you're an infectious disease professional from a facility and you're not sure whether or not they can address the epidemic, that in itself is a problem. And I would think probably indicates that that group is probably not well prepared either. And 55% of facilities have not committed to provide additional infection prevention control resources as a result of the Ebola crisis. And I think that that is really something that needs to get done. And so I think the words from Thomas Frieden, director of the CDC, need to be heeded, that an outbreak anywhere can be a risk everywhere. And I'd like to, thank you for coming for this portion of the talk. We've got an example here of a poster that I saw going into one of my doctor visits at Baptist Health Lexington. I was asked 3 times if I was visited Liberia. I told them no on each time. Really, at the time I registered, the time the doctor saw me, the time I exited. And so I think during the epidemic, we were very much in touch, at least in Lexington, in our preparedness. And Dr. Rice-Leach, I think, will add to this. And again, I'd like to especially thank Dr. Elders for help with the slide presentation. Some of these slides, as I said, were hers, and I merged them with some of my own.